Hello. Welcome to today's video. In this short video, I will attempt to explain about the Malaysian National Health Accounts, or short, MNHA. This video is actually part of a homework given to me and my colleague here at NHF. Before I start, I'd like to inform that the majority of the information provided here is from the Malaysian National Health Account's Health Expenditure Report 2006 to 2020, which is also available in the MNHA website. Okay, so let's get started. What is a National Health Account? A National Health Accounts, NHA, is a systematic framework used to analyze and track healthcare spending within a country. It provides a comprehensive overview of how financial resources are collected, allocated, and utilized in the health sector. The primary purpose of National Health Accounts is to provide accurate and detailed information about health expenditures, allowing policymakers and stakeholders to understand the financing flows within the health system. NHA track both public and private health expenditures and categorize them into different components. We will talk about the components in more detail later. A brief history. The first steps in the establishment of NHA were taken in the 1960s, when a study was conducted to compare the costs of health care in 6 different nations. However, as more nations joined in the effort to track the flow of health spending, the significance of health accounts becomes more apparent. Discussions towards the initiation of NHA in Malaysia started in 1999. The Malaysian Ministry of Health and the Economic Planning Unit of the Prime Minister's Office joined forces to develop the Malaysia National Health Accounts project after receiving funding from the United Nations Development Program in 2001. The project's output includes the first MNHA Health Expenditure Report and a report on the MNHA classification system, also known as MNHA Framework. The MNHA project successfully demonstrates the advantages of using a health account as an evidence-based tool for deciding health policy, which led to the creation of the MNHA section within the Planning and Development Division of MNHA. Following its institutionalization, the MNHA section continued to further standardize its methodology under the guidance of an international consultant. Since then, yearly reports on health expenditures time series were released. From 2022 on, MNHA will release time series data for national health expenditure based on the length of the 3 most recent Rancangan Malaysia RMK cycles. The MNHA Framework. The MNHA Framework is based on international NHA classifications, with minor changes made to meet local policy requirements. The framework classifies all expenditures into 3 main components: sources of financing, providers of health care, and functions of health care. Another way to look at it is the components answer 3 important questions: who pays for health, to where and whom payment are being made to, and for what payment is made. Expenditures by sources of financing can further be divided into 2 major categories: public and private sector. For the public sector, this includes expenditures by the federal government, state government, local authorities, social security funds, and other public entities. For the private sector, it includes expenditures by private health insurance, managed care organizations, out-of-pocket expenditures, and also non-profit institutions and corporations. Expenditures by types of providers of health care is looking at categories such as hospitals, nursing and residential care facility providers, ambulatory health care providers, retail sale and medical goods providers, public health program providers, and general health administration. Expenditures by functions of health care are categorized to 2 main categories: the core functions of health care and health-related functions. Core functions of health care include services of curative care, rehabilitative care, long-term nursing care, ancillary services, outpatient medical goods, public health services, health administration, and health insurance. Whereas health-related functions include capital formation, education and training of health personnel, and research and development in health. The MNHA Framework captures and reports health spending as total expenditure on health (TEH). The calculation of TEH includes health expenditures and all health-related expenditures components from both public and private sources. Therefore, this refers to all expenditures related to improving health, from medical care, prevention, promotion, rehabilitation, community health activities, to health administration and regulations. It also includes health-related expenditures, which is the capital formation of health care provider institutions, education and training of health personnel, research and development in health, and all other health-related expenditures. This is different from current health expenditure, CHE, which excludes capital spending, education and training and research and development. Therefore, CHE figure is always lower than TEH. However, it is important to take note that CHE is used in reporting of the System of Health Accounts, SHA. SHA is a manual produced by the World Health Organization, Eurostat, and related international organizations of the Organization for Economic Cooperation and Development, OECD, in order to create consistency when comparing health expenditure across different countries. From what we understood so far, in order to come out with the MNHA report, massive amount of data is required from various parties and organizations. Before the process of data collection takes place, a detailed definitions of what constitutes health expenditure, institutional entities, and types of disaggregation were drawn up based on inputs from several documents, committee meetings, and consultative advice from the internal and external MOH sources. This whole process is called data source networking. After the list of data has been identified, data is then collected. Both primary and secondary data were used in this analysis. Primary data was collected in several formats through multiple MNHA surveys, and secondary data were taken from various data sources, reports, bulletins, and other documents. The full list of the agencies that contribute to the data source can be found in the MNHA report. All data were then analyzed separately by identified group of agencies. Whenever raw data is unavailable, analysis was done using globally recognized, standardized estimation methods. Lastly, verification and validation of data is performed at multiple levels to ensure the quality of the final outputs. Let's take a look at the summary of the latest MNHA report, which is the year 2021. The summary slide can also be found from the MOH website. Malaysia spent Malaysia 78,220 million for health. This TEH is 5% out of the gross domestic product (GDP). TEH per capita is Malaysia 2,401. Out-of-pocket payments. OOP is 31.5% out of the TEH. In terms of source of financing, 57.9% was from the public sector, where 49.3% out of this was from Ministry of Health. 50.4% of the TEH was spent on hospital care. And in terms of functions, 57.8% was for curative care. That's all the time we have today. I hope this brief explanation can give an overall view of what MNHA is about. Thank you for watching.